Welcome to this lecture on theories, models, and frameworks for implementation research. My name is Pilvikki Absetz, and I'm a professor of public health at the Tampere University in Finland. This lecture is number 3 in the fundamentals program. Today we will talk about different functions of theories, models, and frameworks, which I will call TMF in implementation research. We will also discuss some similarities and differences between TMF commonly used in implementation research, and you will get some guidance for selecting TMF for your project. I want to start with an implementation science challenge, which I see is in that implementation science was set to answer the need to implement evidence-based interventions into clinical practice in high-resource settings. EB were typically specific biomedical interventions, and the change mechanisms for EB had been identified in basic research and confirmed in efficacy trials. But the contextual implementer and participant-related factors were initially not in the primary focus, although they have become more important afterwards. Also, the adoption of implementation science to complex interventions for health promotion and NCD prevention specifically, and in diverse settings, including community and low-resource settings, puts some extra requirements, because they have brought context, implementer, and participant-related factors much more in the center of implementation research. And there is a need to understand these better and to be able to influence them as well. So what is very relevant is the fit with context, implementers, and participants. And questions such as what is an appropriate level to intervene, how to contextualize the intervention while retaining mechanisms of change, how to utilize contextual facilitators and to intervene on contextual barriers in implementation, and how to change behavior and practices have become very important questions that we seek answers to. And this is where TMF can really help us, because they organize and help to understand complex systems and multi-component phenomena. They help to interpret events, to predict what will happen, and to make an impact. In implementation research, they guide the selection of levels on which to intervene, determinants to target, methods or techniques for change, and process measures that we will want to apply. My own entry point to TMF and implementation research was over 20 years ago, when we started a type 2 diabetes prevention study and wanted to utilize health psychology theory to understand better the changes, and also to intervene on people's behavior. At that time, I was very much focused on the effect on individual level. Earlier efficacy trials had already established the link between lifestyle changes and type 2 diabetes, and the lifestyle change was pursued with counseling based often on clinical experience, but I was very interested in the mechanisms of change, and especially the behavior change theory that informed on these determinants and evidence that had been already gathered from research. And also to think about the specific behavior change techniques that could be utilized in interventions, and also these based on theories and evidence that had started to accumulate rapidly. So there was a real need for systematic intervention planning based on behavior change science, and this happened simultaneously in many parts of the world. Behavior change science has evolved a lot in the last 20 years, and I will talk more about that and mechanisms of change in lecture 3B of this program. But we quickly realized that program impact required not only real-world effectiveness to be established with the intervention, but also successful implementation. And there we needed to answer many different types of questions regarding the target populations, the stakeholders, and partnering with them for program delivery. Also how to plan and ensure implementation of the program, and sustainability of the program beyond the project life course. In conducting implementation research, one of my main messages is that any one TMF will not be sufficient. You will need theories to cover several functions, and we will go into those functions shortly. For some functions, you need different theories on different levels. And it's also important to remember that there is no single TMF which is perfect, nor the only right one to use. Each one of them has their pros and cons, and it's always a matter of choice. And there are different things that you want to consider when making those selections. So coming to the functions, this figure is adapted from Nielsen's work, and he has distinguished between these three different functions of TMF. Guiding the process of implementing evidence into practice, understanding the mechanisms for change, and with respect to implementation research, especially mechanisms for implementation outcomes, and then the third function, evaluation of implementation. And there are lots of different TMF also named in this figure. We will hear explanations of some of them, but not all in this lecture. And then in the next lecture, some of the others as well. So let's start with the process models. Intervention mapping was an approach that was developed for health promotion program planning, and this is a behavior change science-based approach with 6 different steps that will take you through the planning to the actual program adoption and implementation, and all the way to evaluation, starting from a comprehensive needs assessment and then defining the changes you want to achieve on different levels of intervention and what are the underlying determinants, identification of those, selecting the best theoretical methods and the most feasible practical strategies, then planning the program specifics, and then the adoption and implementation. Not that all of these would happen in such a sequence. Many things happen simultaneously and are overlapping, taking you back and forth. So in that way, maybe calling it a phased approach is inappropriate. This framework was okay. Let's go back a little bit. So when doing the planning for the adoption and implementation, you need to go back to needs assessment and complete the process all over again, but this time for the implementation and not the participant change, but for the change that is required for implementation. And for that specific process, Fernandez and colleagues described implementation mapping in their article, how these same steps can be used for assessing needs for implementation and identifying program adopters and implementers, and then stating the outcomes and objectives for those. And similarly to intervention mapping, then choosing theoretical methods and strategies for implementation, etc. So that's a very, very useful process model. In the needs assessment part, really thinking about the context is an important thing. Proceed model is another process model which is very useful for needs assessment and helps in thinking about the chain of influences and things that will need to be addressed in order to make the change happen. We used this model in our Kerala diabetes prevention program in India, where we did a comprehensive needs assessment. The publication is linked on this slide. And with earlier research findings, statistics, Gray literature, and some qualitative interviews, we found out many things that helped us in the intervention planning. For example, assessing the health of the population, we found that NCD risk was really high, and prevalence of type 2 diabetes was also extremely high in this population. And many behavior and lifestyle factors, as well as environmental factors, that were accounting for these health problems. But then what was behind those? There were factors on individual level in the upper part shown, and then there were also many factors from the policy level to the community level and interpersonal family level decision making and social support issues. When looking at health promotion and health education, we saw some of the methods that had been used, but overall a short history of policies and programs related to NCD prevention in the country. So this was very helpful for us to identify the levels on which to intervene, and also led us to think about some of the intervention objectives and strategies that we would utilize. So on which levels to intervene? Social ecological model is a good reminder of different levels. KDPP targeted individuals within families and communities. So those were the levels that we worked on there. The healthcare organizational level was too scattered in the country to utilize that as our implementer organizations, as we had in many other countries before. Another useful model, a process model, is the PRISM, Practical, Robust Implementation and Sustainability model. In this model, what I really like is the way that intervention is looked upon by the participants and also the organization with different layers of people, from the professionals, from the leaders to managers and staff, and also how the implementation then is influenced by participant characteristics, organizational characteristics, but also external environment and implementation and sustainability infrastructure. And how re-aim model for evaluation is included in this model as well. So things that I talked in an earlier slide about how to reach the target population, how to support adoption of the intervention and the implementation and maintenance, and then to evaluate those as well. The second function, understanding mechanisms for implementation outcomes, and this, as I said, I will talk more in the next lecture. But let's look at some parts. Determinant frameworks, first of all. Consolidated framework for implementation research is a practical framework to help guide systematic assessment of potential barriers and facilitators. And this model will be explained and a practical example given in another lecture. But briefly, it consists of 5 different domains: the intervention, the inner setting where it is implemented, the individuals involved, the outer setting, the larger, broader context, and then the process of implementation. Theoretical domains framework is another where determinant framework, which compiles constructs from different theories. There are so many different behavior change theories which have partly overlapping concepts and constructs, and this framework has distilled those domains and identified 14 different domains, and there are some examples of the specific concepts within those domains that might be needed to address as determinants. The benefits of the framework are, for example, that it covers different potential mechanisms of influence. It makes a distinction between different types of influence, and it's easy to link behavior change theories to behavior change techniques. And I will show a practical example of this in my next lecture. There is also a paper that gives a good guide to using this framework to investigate implementation problems specifically. Classic theories are theories of behavior change and motivation, and those will also be explained in more detail in my next lecture. But I will only want to show the COM-B model with 3 necessary preconditions for behavior. And this is also a model that takes the key concepts or categories from many different other theories. It's the center of the behavior change wheel, which some of you might be familiar with. That's another sort of tool for intervention development, with the sources of behavior in the middle, then intervention functions and policy categories in the outermost line. But what is important here is to consider whether program implementers have sufficient capabilities, opportunities, and motivation for implementation, for the behaviors that the implementation requires, and then also, do the potential participants have sufficient capabilities, opportunities, and motivation for participation and for benefiting from the intervention. So for the behaviors that they would need to undertake to benefit. Implementation theories include, for example, normalization process theory, which is one of my own pet theories. This is a participatory approach to implementation, which is why I like it very much. And there, the first important construct is coherence. So does this make sense? Does adoption of this new intervention make sense? Is there a win-win for different stakeholders? Then cognitive participation, engagement, ownership, and advocacy by the stakeholders. Collective action, making it work together, sharing roles and responsibilities, making sure that there is sufficient training and capacity building. And finally, reflexive monitoring, so evaluation and appraisal, learning and development, not stopping to do something, but really learning and improving while you go. And this can be done in a cyclical way. We utilize this theory in our YIPI project, Youth Co-Production for Sustainable Engagement and Empowerment in Health, where we are running co-design workshops with multi-stakeholder groups, and to first come together to assess needs and reflect findings from formative research that we've conducted, and and also reflect on assumptions from our initial program theory. That in order to build the sense of coherence here. And there the role of participants is as interpreters. And then continuing to co-design of the intervention content where participants are co-designers and able to really engage and get ownership for the intervention. Then co-develop implementation strategies, and there the participants are as future implementers, and finally then define key process and proximal outcome measures that are also relevant for the participants, and they're the participants as evaluators. So this also allows different roles to be taken. The normalization process website has measures for the constructs that can be used, and there is also a toolkit that helps to think about implementation problems. And finally, evaluation frameworks. For example, implementation outcomes framework by Proctor and colleagues outlines 8 different implementation outcomes. I will talk about acceptability and fidelity in a little while. These implementation outcomes then lead to service outcomes, improved service outcomes, and improved client outcomes. The paper by Proctor and colleagues that reviews work done with this framework also defines what the concepts mean, and then also describes the theoretical basis and other related terms in literature. But also I find very useful the salience by implementation stage and the available measurement that it also details here. As promised, another framework for acceptability can be evaluated pre-intervention and post-intervention among participants, but also among implementers. And these are the 7 dimensions of that theoretical framework, which are based on review of earlier literature, and some examples of what those different constructs entail. Also, fidelity of implementation is important to look at it from multiple perspectives. So in this example, the Smart Family by the Finnish Heart Association is a healthy lifestyle program with tools for families and professionals. And there, the fidelity of the training program, the fidelity of the delivery of the lifestyle coaching, but also the question about whether the parents and families use the tools as intended. Re-aim, which I already mentioned when talking about the PRISM, has a double focus on the implementation outcomes, but also the effectiveness outcomes. And this, while evaluation framework, this is also useful for planning the program initially, because by planning these dimensions carefully, you can also try to make sure that you will also achieve what you have planned for when in your evaluation then to be established. There are some planning questions for the dimensions and things that need to be considered in the implementation, and different measures, potential measures for outcomes. A couple of TMF for specific purposes also in the end. Equity in health or inequities in health are a big problem in our global world. And this is a model that is specifically developed to diminish inequalities and inequity. And from the very sort of needs assessment, population health status starting point, to planning the program, to designing the what will be done, and the implementation and evaluation of the program. This model helps to keep equity in the focus. There are also other equity-focused TMF, and the review outlining those and describing those is linked on this slide as well. The last framework that we will talk about in this lecture is the framework for going to full scale, and this is for taking an existing innovation and setting up the situation for scaling up, defining the program components, delivery, and targets that will be scaled up, and testing the scale up and going to full scale. So those are the phases, and there are adoption mechanisms and support systems that will need to be considered and utilized in this process. There is a practical example of a hypertension and diabetes control program with different existing components, innovations that can be utilized, and then the setup of that with a situational analysis on at patient and provider level, and different scale-up dimensions, population coverage, intervention package, and integration to health system, then testing the scale-up and as an output having materials and protocol for going to full scale. There are useful web-based tools to guide TMF selection and utilization, and just to mention a few, this is the dissemination and implementation website, and there is a good tool for choosing TMFs. And then another one is the University of Washington Implementation Science website, which also here is a selection of implementation strategies, so quite helpful as well. Key messages from this lecture are that, as I said already in the beginning, in conducting implementation research, remember that any one TMF will not be sufficient. TMF are needed to cover several functions and different levels, and no single TMF is perfect, nor the only right one to use. Findings from your needs assessment and earlier literature are your best guides when selecting, and there are good resources also to help you identify and select TMF. Here are key references for TMF that we went through in this lecture, and also the other references used. Thank you for being with me today.